all the challenges, of getting to the patient first of all, and then secondly making enough space to work. So all important thing, all key concepts that can happen in difficult airway management. So without further ado, I just wanted to do my normal disclaimer. I don't have any financial conflict of interest. I don't have any stock in the video laryngoscope manufacturer, although I sort of wish I did. And then I'll talk about some specific products here, but I'm not necessarily endorsing them. And so, long story short, I've gotten to meet most of you, I think, in one course or another, but I've had a pretty fun course in EMS as an EMT and kind of working my way through the system as a paramedic, flight paramedic, and now a EMS and emergency medicine physician. So to set the tone, I'm just going to show a little quick failed intubation video. And can you guys hear the audio at least okay with this? All right, so famous lies in airway management. I see the cords. The cords are right there. I'm through the cords. And clearly not, right? Because now we're in the process of doing a surgical airway.
All right. Got it. You have a picture? Can you feel the? I got feel the difference. I'm through. You're right there.
So there's actually this patient's almost in cardiac arrest. So there's actually not a lot of bleeding. Having done this a couple times now, there's actually quite a bit of bleeding in patients who are alive. And if you ventilate them, there's this fine spray of blood that kind of comes out once you're through the cricothyroid membrane. So wearing eye protection, like good face shields, is really important in a situation like this.
We got color change.
All right, so lots of truths to airway management. And I talked about this in the beginning, right? So airway management is more than just intubation. Intubation can be life-saving, but it can also unfortunately harm patients as well. And so today we're going to talk about artfully managing the airway in a way that's productive and part of the resuscitation, and hopefully as safe as possible. So if you have questions, feel free to jump in, interrupt, raise your hand if I don't see it. And I think if you put something in the chat box, I can see it too. So remember, airway management involves a lot of BLS, and it's a team effort. And so really the purpose of intubating somebody, or airway management, I should say, is not just to intubate them, but it's to manage the patient to ensure that the airway remains patent. And the last part is to optimize the resuscitation, right? Because our goal is that we want a good outcome for the patient when they get discharged from the hospital, right? They got to be neurologically intact, right? So it doesn't matter if you get the tube out on the first attempt, but it takes you 5 minutes to do that, and the patient's pulse ox is 30% when you get the tube in, right? That's a first pass intubation success, but likely going to result in harm for the patient, right? So there's lots of reasons that we intubate people. I know at Riddle, SAI is not something that you do right now. That may be an option in the future, but most of the time that you're intubating somebody, it's because they are in respiratory failure, they're unresponsive, it's a cardiac arrest, right? There's something severely abnormal with their airway, right? So, we look at our advanced airway management possibilities without SAI, right? So if they're awake and alert and their gag reflex is intact, we do things like put them in a position of comfort, give them high flow to use our adjuncts, CPAP, nasopharyngeal airways, BVM, and go from there, right? And if they're unresponsive, then we end up doing all those things plus some sort of advanced airway management, whether it's endotracheal tube or supraglottic airway, right? So in patients who get intubated in your population, right, mostly these are what we consider crash airways, right? They're obtunded, they're in a cardiac arrest, they're about to be in a cardiac arrest. And so if you don't intubate them, they're going to die or they're already dead, right? So lots of things go into that decision, right? You want to decide how far you are from the hospital. How good are you at intubation? Which it sounds funny to have to say that, but realistically, right, you think about it, there are some, if you really critically evaluate your own performance, there are probably some of you who are pretty good at intubation, and some of you who are amazingly good at intubation, right? And you fit somewhere in that spectrum, right? So it's important to know where you fit, and obviously you need to practice and refine your techniques. All right, so lots of considerations that go into airway management, but in the interest of moving quickly through this class, I want to kind of get through to some of the meat of it. I always have to talk about the anesthesiologist, right? So I do think that emergency airway management lies solely in the domain of ER and EMS physicians, because if you look at the American Society for Anesthesiologists, this is their algorithm for management of difficult airways, right? And in many times they decide they're going to cancel the case and awaken the patient, right? How many times can we say, you know what, I actually didn't want to go on this 911 call, so we can just undo and I'll go back to sleep, or I'll go back to my station, and maybe tomorrow we'll try again, right? So that works in the anesthesia world. It doesn't necessarily work in our world, right? And obviously I'm being a little bit facetious here, but the anesthesiologists, their end result has to be much different than ours, right? Many of their cases are elective cases, and those patients must have a good outcome. All right, so how do people die from intubation, right? Because I did say that intubation will kill people, and it's because there's lots of inappropriate ways to use a laryngoscope, right? So if you give sedation-assisted medications for intubation, or even sedation-assisted or sedation meds as part of an RSI, those medications all reduce blood pressure to some degree, right? If you don't do a good job pre-oxygenating and washing out the nitrogen from the lungs, and that the patient's hypoxic for a long time, they can get an anoxic brain injury, they can do poorly. And then the last thing is they can get really acidotic, right? So if you take a really long time to try to get them ventilated, you're not managing your vent parameters correctly. Again, all possibilities, that can make things significantly worse. Right. And unfortunately, there are attorneys out there that specialize in finding failed airways and pursuing malpractice suits against people with failed intubation attempts. And it's sort of, I can't tell you how upsetting it was to, as I was kind of researching some materials for this, you come across Google ads all over the place for the next month, talking about intubation complication malpractice attorneys. All right. And so unfortunately, it goes without saying, but there are cases in the news that you see all the time about failed intubation and failed airway management. So we've seen all these things before, right? You've seen this oxygen hemoglobin, this saturation curve. And you've seen that people have said, hey, it can take as long as 8 or 9 minutes to desaturate if someone stops breathing, right? Anyone heard that before? You've all seen some of this slide somewhere in your paramedic physiology school. And the thing I want to point out that is that these are young, healthy volunteers that were amazingly given a dose of paralytic and then allowed to desaturate, and then had assisted ventilations with the BVM. So these were med students essentially that had this research done upon them many, many years ago. But these are all young, healthy, young adults, right? So we know that in critically ill patients, this apneic time that's present before desaturation is actually much shorter. It can be even, as short as 30 seconds or less, right? So lots of refinements to your pre-oxygenation strategies, right? So it's important to really maximize your BLS, right? So we talk about when you use a BVM, you need to either have a good mask seal or be squeezing the bag a little bit, because there's a duckbill valve that kind of keeps your exhalation going in one direction. And if you're not squeezing the bag slightly, or you're not making a great mask seal, and you're just hovering the BVM mask over somebody's face, all that happens is you're mostly shunting the oxygen not into the mask. It's just kind of sitting in that reservoir bag and coming out the back of the BVM. Make sense? Right. Have you all heard this before? All right. So just little things like this are important to have good awareness of. All right. On our non-rebreathers, right? We talk about them as non-rebreathers, but the reality is we take off this one little disc, right? And that's, so what is this mask I'm putting on the screen? What's it actually called? The technically correct name for this?
It's a partial non-rebreather.
Partial non-rebreather, right? And so we think of it as supplying close to 100% FiO2, but in reality, because we take this valve off and a lot of oxygen escapes, it probably provides only about 65 or 70% of oxygen. And that's one of the reasons why in the crashing patient protocol, if someone's in significant respiratory distress, the protocol is to use the BVM to directly assist their ventilations rather than just putting one in a non-rebreather, right? Makes sense? So lots of things make airways difficult, right? And so there are 4 dimensions to this difficulty, right? So we want to talk about difficult laryngoscopy, difficult crikes, difficult rescue airways, and difficult BVM ventilations. And so by an exercise, right, if I tell you that there's an arrow here in this FedEx truck, How many of you see the arrow right now as I just put it on the screen? Did everybody see it? I think the answer is no. Usually when I do this in a live audience, only about half or so see the arrow. But if I tell you the arrow looks like this now, do more of you see the arrow present? Yeah, in the logo, right? And absolutely, because the arrow is right here. And the same thing applies with difficulty in airway management, right? So if you're conscientiously looking for difficult airways, you'll be able to visualize, you'll be able to anticipate them and predict them. And we actually know from some of our ketamine for SAI studies that if you can anticipate a difficult airway, you actually do a much better job of intubating the patient when you know it's going to be difficult in advance rather than when you get surprised by it. Right, so we use this acronym MOANS for people who are difficult to bag mouth mask ventilate. So if they have a difficulty in making a mask seal, if they're obese, they're aged or elderly, if they have no teeth, right, because now you have no structure in your midface. And if they are stiff, which means their neck doesn't extend properly, or if they snore, like they have a really large tongue, then they may be difficult to intubate, right? What is this going to be? Does that look like a difficult airway? Of course, right? It looks difficult. It probably is going to be difficult, right? And here's some other examples of difficult airways out in the wild, right? So we have big overbites, we have morbidly obese patients, and so on. But what about difficult crikes, right? Why does it matter if someone's made a difficult crike? It's because the crike is our only available ventilation technique if you have a failed airway, right? So if you can't intubate them, and you can't ventilate them with any other method, like a BLS airway, like a mask with a nasal trumpet or nasally intubate them, then your only choice is to do a crike, right? So people who are difficult crikes are those who meet the short acronym, right? So they have surgery or prior trauma or a disrupted airway, there's a hematoma or infection there. If they're obese, right? So we talked about obese patients, so there's an access problem because you need a little bit of space around the patient. Radiation because of the scarring that causes in the neck tissues, and then any kind of tumor, which again is one of the reasons that people get radiation therapy, but tumors can displace the anatomy as well. What about difficult rescue airways, right? So we have LMAs or iGels and King airways. And of course, how many of you remember the combi tubes, right? The combi tubes that looked brutal to put in, and when you tried to put one in, were kind of difficult because of how big the mouth opening had to be, right? And so all of these new or supraglottic devices are really refinements in the same concept of the combi tube, right? We really do our best to occlude the esophagus, and we leave only one portal of entry to the lungs, which is the trachea. But if you can't open the mouth a lot, right, or there's some sort of anatomical disruption of the larynx, or they're a distorted anatomy because of an infection or a tumor, it's going to be really difficult to get the airway to seat. How many of you tried to put a King airway in for a failed airway or an iGel, and it didn't quite get a good chest rise? Anybody have that happen to them? I know I have, right? And so what you have to do is do some troubleshooting with the airway, right? It takes a little bit of manipulation, but when the King airway people came out and they did their sales pitches, right? It's like the Ron Popeil, you set it and forget it, right? You shove it in there, you inflate the cuff, and it's good to go, right? But the reality is it's not. And the same thing applies with the iGel, right? You can't just stick it in there and expect it's going to work. It does take a little bit of troubleshooting. It takes a little bit of manipulation sometimes to get a good seal. So who's going to be difficult to intubate, right? So we can do things like we look externally, right? And things that look difficult are going to be difficult. There's a 3-3 tool rule that we can use, the Malampati score, which the anesthesiologists mostly like to do, but it doesn't really change our world too much in EMS. There's an obstruction or an issue with neck mobility, like a C collar for trauma. And here we have this, I think it's like a 1980s era C collar in this picture, but you get the point, right? So I'm going to fly through these because most of the time when you're intubating somebody, it's because you have no other choice, right? They need some sort of airway. They're unresponsive. We're not selecting people that are going to be good candidates for intubation. They just need to be intubated, right? But if you can't open their mouth 3 fingers, if you don't have 3 fingers of space down beneath their chin, and you don't have 2 fingers of distance between their cricothyroid membrane and their hyoid bone, they're all going to be difficult to intubate. And the reason for that is this area that you see on the screen, the space where the 3 fingers are, that's where the tongue goes when you try to intubate somebody. You have to displace the tongue into the floor of the mouth. And if there's not all the room there to put the tongue, this is when you have those people with big floppy tongues that seem to block every attempt you have to try to get into the trachea. Right, and then here we have a patient who has, in this case, it looks like someone with tetanus, but in reality, it's they they had a mandible fracture and they can't open their mouth any more than what you see. And you have people with small chins, this is micrognathia, right? So they have a receding mandible. And then here we have the same kind of profile, but a little bit closer up, right? And obviously here we have somebody who's morbidly obese with a lot of redundant tissue over their neck. The Mallampati score is assessed when you have a patient sit forward and they stick their tongue out and say, ah. How many patients have you tried to intubate that before you intubate, then you can ask them to say, hey, sir, ma'am, can you sit all the way up for me? Stick your tongue out and say, ah, let me decide if I'm going to intubate you, right? That was none of our patients in EMS, right? They're in extremis when you're going to intubate them. So again, this lives in the anesthesia world, but it's not really that useful, I think, for us. You can see the different degrees of difficulty here. All right. People have upper airway obstructions, can be difficult to intubate. Right, in this case, we see someone with a pretty bad dental infection. The good news is that the swelling under his chin is not bad, it's actually abscess. And these patients are really, really challenging to intubate. In fact, most of them go to the OR for intubation. And the reason for that is that this is a slow moving process, fortunately. And it's one that, you have a little bit of time to work with. But there are airway nightmares that can happen very quickly. So this is a hematoma in a 12-year-old who was shot with a shotgun and ended up with a shotgun pellet that punctured his innominate artery. So has a pretty impressive expanding hematoma. And this is a very quick process. Here we have somebody with a stab wound to the neck, and there's a hematoma formed as well. You can see it in the difference between the shadows at the clavicle, and obviously there's a yellow arrow pointing to the stab wound. But we also see these in elderly patients, right? So this is an older person who had a clothesline type injury who's anticoagulated. So a nursing home patient who was on warfarin, who slipped and struck her neck against the front edge of a walker, ended up with a hematoma. And when they actually went to go manage the airway, this is the amount of edema that was present, right? So looking at that anatomy, it looks sort of impressive from the outside, but inside, I mean, you can see how much swelling and distortion there is. Right, sometimes we see people with these peritonsillar abscesses who have lots of uvular deviation, right? That uvula should be normally hanging straight down in the back, but it's deviated off to the patient's right, which poses a challenge as well. So I got 15 minutes left, so I'm going to go through pretty quick. I did tell you that when people know that the airway is going to be difficult, they do better at intubating them. And this we saw with our ketamine study, right? So when people did not predict a difficult airway, but they encountered one, it took on average 2.5 attempts to intubate them. But when you anticipated a difficult airway and you encountered it, it only took about 1.8 attempts on average, right? So if you know something's gonna be hard, there's something about not getting caught off guard that helps you be prepared and helps you succeed in airway management. All right. So one of the big things in airway management is the head positioning, right? So everyone talks about the sniffing position as the best way to manage an airway, but I think the better concept is to think about getting the ear and the sternal notch as close as possible, right? So if this distance between the sternal notch and the ear is minimized, right? So if you can minimize this distance right here, then I think you do really well in terms of managing areas. So again, the distance from here to here, you want to try to minimize. And it might involve building a ramp with your sheets or blankets or pillows. All right, so the bigger the patient is, the more sheets and blankets that you might need to be able to accomplish this. All right, we talked about bag valve mask ventilation, optimizing it, a 2-person effort at the minimum. Right, when you use some sort of adjunct, oral airways, nasal airways, get them in a good position, ramp them, and controlled squeezes of the BVM. All right. How about tongue control, right? So how many of you, when you use anyone have a favorite here? Macintosh blade, Miller blade, what's your favorite? Someone throw out your favorite blade here. I'm going to say probably the 4th. Everyone likes Mac, right?
Yeah. Straight.
All right, we got some Miller blades. Good. So I think it sort of doesn't matter what your favorite is, as long as the blade works for you, it's the best blade, right? But one of the most important things that you have to do is control the tongue, all right? And when we do education with the residents, sometimes we actually have a video scope. We use this, the Karl Storr CMAC, right? So it has the same geometry as a conventional MAC 4, but we have a video at the end of it. So we can actually take this video screen, turn it away from the intubator, and let and let them use the blade like they would use a normal, non-video laryngoscope. And one of the important things I've noticed is that a lot of people just try to take the blade and they put it in the midline and lift up, right? They look for the epiglottis. The problem with that is that about 80% of the time you can get away with it, and you can kind of put the blade in the middle. But how many of you, thinking back to your last difficult airway, you put the blade into the patient's mouth and the tongue flapped over on either side of the blade, right? Anyone have that happen to you? I know I have had that happen to me, right? And that's a tough situation. And the reason for that is because their tongue was so large that the flange on that number 4 Mac blade could not control it, right? So when you use a Miller blade, one of the most important things you do is what? Sweep the tongue off to the left, right? That's the only way the Miller blades work. The same thing applies for using a Mac. You got to sweep the tongue out to the left. What about your stylet? Anyone heard about the straight to cuff issue with stylets? Right, so how many of you had a situation where you have a great view of the cords and you go to intubate them and you just can't get the tube to make the bend, right? Or you get it right at the glottic opening, maybe you can't get it all the way, you can't get a little bit further, and the tube stops short. Anyone have that happen to you? It's so maddening, it's frustrating, right? And the reason for that is relatively simple, right? So if you have the tube stylet curved in the endotracheal tube, what happens is the distal end of the stylet can actually hit the anterior portion of the trachea. All right, so if you actually change your positioning and you change your cuff a little, your stylet a little bit, so you keep the stylet straight and you put a bend in right where the cuff starts, by putting this tube in a straight line, you actually give yourself a lot more room to maneuver and a lot more room to get the tube into the trachea. Makes sense? So straight to the cuff with your stylet and your endotracheal tube. How about the bougie? Anyone a bougie fan here? Right, so hands down, if you gave me one airway device to choose and you gave me a choice of any video laryngoscope in the world or a gum elastic bougie, I would actually choose the bougie over the video laryngoscope. Now, in a perfect world, I would have both, right? I have a video scope and a bougie. But if you made me pick one, I would pick this $3 piece of plastic over a $10,000 video scope. And the reason for it is it's so versatile, right? So how many times have we had this issue where you see somebody who you try to intubate and you can see the base of the epiglottis, but not anything else, and you try to intubate them and it's pretty tough, right? So we, in this video, have a person who gets a great view. So if you look in a moment, they're using their pinky to retract the lip. They get this grade 1, maybe 2 at best or at worst view. And now they're deliberately going to give themselves a 4 view so they can demonstrate how to use a bougie, right? So now you have a grade 4 view. I see nothing at all. You can take the bougie, directly lift the epiglottis. Maybe you can see the cords. And if not, you can gently advance the bougie. You got to be gentle. And it should stop when it hits what structure? Where should the bougie stop if you're in the trachea? In the carina, right? So it should stop. What was that?
The cric rings?
You might feel it against the cricoid rings, but by all means, the bougie should stop when it hits the carina, right? So usually if the bougie doesn't stop before 50 centimeters or so, you're in the esophagus, right? So sometimes you feel the cricoid rings as you bounce through, but if nothing else, it stops at the carina, and that helps reassure you that you're in. And then you can just slide the endotracheal tube over the bougie. One little tip though, when you're using a bougie and you're putting a tube over it, sometimes the bougie can hang up at the endotracheal tube can hang up at the aryepiglottic fold. So right here, as you can see on the screen. And the reason for it is that there's a little gap that gets created, the bevel on the endotracheal tube versus the path of the bougie. And so all you have to do to fix this is take the tube and rotate it 90 degrees so that the bevel faces downward, and then it lets it slide like opening. This more earlier about a trauma patient with clenched jaw, right? A lot of issues with managing their C-spine, right? You have to protect their C-spine. You need to manage airway appropriately. So one of the most important things, and it sounds silly, but I'm going to remind you, you should probably open the collar on these patients, right? You should open the front of the collar and hold manual C-spine stabilization. But I see lots of people have trouble intubating somebody with a collar on because they can't get their mouth open, right? Because if a properly placed C-collar will restrict your mouth opening. That's if the C-collar doesn't restrict your mouth opening, it's not properly sized and fitted, right? But once you get the C-collar open, you have to hold C-spine stabilization. And a lot of people try to do it like this, right? Where you have someone kind of kneeling down next to the intubator, facing the same direction and trying to hold C-spine. I think that's a little bit tougher to do because now you have two people trying to occupy the same space, and it's harder to keep the head immobilized properly because you're kind of holding something down on the table. But if you actually flip it and have the assistant kind of hold the C-spine from the anterior portion of the patient, that helps so much in keeping them intubated well. And this is what it looks like in a field setting, right? Where you have an airway manager, the intubator, you have their assistant, and you have somebody from the anterior holding C-spine stabilization. All right, so tips about intubation for C-spine or with C-spine immobilization, right? Don't forget to open the front of the collar, manually stabilize the C-spine from the front, use a bougie, and have a couple rescue airways handy. All right. What about other trauma patients, right? So if they have a disrupted airway, so these are people who are like clothesline type injuries. Now it's going to be snowmobile season soon. We have people who snowmobile through the woods and get like a tree branch across their larynx, right? Sometimes they have tracheal lacerations. In those cases, sometimes you actually have to put the tube in through the laceration. If they have a hematoma or some sort of other airway distortion, supraglottic airways can be difficult, and bleeding obviously makes anything with a video scope very difficult as well. So I know I'm flying through this real quick. Any questions so far? All right. So if you have a disrupted airway, and you can't see anything at all, you don't really want to just shove a tube down there blindly, right? Because you can create a false passage. But you might need to sort of stabilize the distal end of the trachea. You can use hemostats or McGill's if you need to for that purpose. You try to place the endotracheal tube directly. Right. What about closed head injury patients, right? So we had heard about this individual who had a clenched jaw. Oftentimes there are trauma patients, and some people think the right thing to do is to use Brutane, right? So a little bit of force, then you force their mouth open, you force the tube and you hold them down. And that unfortunately is the worst thing for patients, right? So that actually increases their ICP. If they have a head injury, it can significantly worsen the brain damage that results from it. And overall, it's barbaric, right? So we think, sometimes we think that using etomidate or ketamine is the answer. We know from our ketamine SAI pilot that we ran, those are the airways that generally don't succeed when given ketamine. These patients need RSI, right? These patients need paralytics in conjunction with the sedative. And as the, primary driver of the ketamine SAI pilot, I'll be the first to say that ketamine SAI is not superior or even equivalent to RSI. There's no replacement for RSI. And I'm happy to say that as a result of our ketamine SAI pilot, there is active discussion at the state level on bringing RSI to the ground in a very carefully controlled manner. All right, so lots of work going on in that arena. All right, what about obesity, right? So obesity was a topic that you guys wanted to hear about. So lots of obese patients out there, lots of good reasons and not good reasons for people to be obese. But I can't stress enough the importance of building a ramp for these patients, right? So you can see how obstructive this airway looks. But if all you do is build a ramp and you get their ear to sternal notch closer together, you've succeeded. So in the hospital, I take every single sheet, pillowcase, pillow. I raid the linen cart and I make everyone mad at me, and I put all the towels I can behind them to get this ramp built. In the field, what do you use? You use the sofa cushions, you use the pillows on the bed. Sometimes you use your first in bag as the base, and you throw padding on top of that. But you use what you have available to you to build a ramp. And of course, if you're in the OR, you have these really fancy, custom designed, single-use foam pillows that are pristine. Lots of other things make obese patients very difficult to intubate sometimes. When you try to put the laryngoscope blade in, how many times has the end of the handle bumped the patient's chest when you try to intubate them, right, when they're really obese? And so the fix to that is just to rotate the laryngoscope 90 degrees and put the blade in sideways and then rotate it anteriorly once you get past their anterior chest wall. Right. It's also difficult to make a mask seal on some of these people. They have a lot of redundant tissue on their face and their neck. And it's difficult sometimes to get enough pressure behind your BVM to ventilate them as well. To help that, what you can do is put an airway adjuncts like an oral airway or an oral airway and a nasal airway, or even two nasal airways and an oral airway, kind of distend all those tissues and give you the best chance of intubating them. All right. So video scopes, I got 2 minutes left, right? So video scopes, tons of them out there. All that matters is that you know your device, you know your product, and you feel really comfortable with it. One of the things to remember though is that the camera for the video scope is at the very end of the laryngoscope. So how many times have you used the video scope and said, I can have this great view of the cords, but I can't quite get the tube in, right? Or it's difficult for me to get the tube in. I think we've all had that experience, whether it's in the hospital or in the field, right? So we have this new phenomenon where we can visualize, but we can't intubate them. And so the fix really is to kind of back the view up a little bit, and to move the blade a little bit more shallow, so you have a greater opportunity to line up the mouth with the trachea, because the tube, at the end of the day, the tube still has to make that bend, right? So if your camera's all the way at the end, then you have it kind of buried to the hilt in the mouth, you might not be able to see, you might not be able to get the tube to bend in the way you need it to. All right, so other things that we see when people use video scopes, right? They try to place the video scope by looking at the screen the whole time. It sounds silly, but you have to remind yourself, look at the mouth, get the blade in the right position, look at the screen, find the glottic opening, look back at the mouth as you try to get the tube in, and then look back at the screen to confirm that the tube is placed. Make sense? So mouth, screen, mouth, screen. You got to switch your point of view between the two. You can't just look at the screen the whole time. All right. And then depending on your scope, there are sometimes rigid stylets that you can get. So what do you guys use at Riddle in terms of your video scope?
AirTrack.
AirTrack. Okay. So a good product, right? It's pictured at the top of the screen, one of the original inexpensive, low cost video scopes that are out there. And do you use the channeled version or the non-channeled? Which one do you normally use?
Channel.
The channel, right? So the channel is good to work with. You can actually put a bougie down the channel sometimes if you need to. That's one thing you can do. Otherwise, the key with using the AirTrack is to use enough Surgilube on the tube so that when you go to kind of peel the tube out to the side, it doesn't get dragged out by the friction against the channel, right? But a good product just requires a little bit of finesse and not putting pressure upward on that video screen, right? So how many times have you used the AirTrack and you pop the screen off by accident, right? So it just makes, you got to hold it low enough on the blade to have it happen to you. All right, my 1 minute left. I'm going to say whether it's a supraglottic area, whether it's a King or an iGel, it's not set it and forget it. You got to lift the tongue up. You got to seat the King airway firmly. And the stripe, believe it or not, is backwards. So most of the times the stripe is on the cephalad portion of the tube, but here it's actually on the caudal side, so it's towards the feet. And it's the opposite of what we have in most Airway products, but I've definitely seen some people coming with King Airways placed backwards, and that the stripe is up and the curve is not anatomic. If you're using the iGel, do you guys have King or iGel at Riddle?
iGel.
iGel. So if you're using the iGel, you want to make sure you have the EMS version, which has that little elastic strap that goes around the head to kind of seat the iGel in place more firmly. There's a hospital version of the iGel that doesn't have that elastic strap. And those are the ones that seem to displace a little bit more. So I'm going to skip this laryngospasm stuff. And I'm going to skip some of the surgical airway stuff. In the interest of getting to my summary slide here, which really is this. You got to be prepared. You got to have your setup ready. Suction, O2 laryngoscope, capnometer, check the cuffing and retrieve the tube. Have a gum elastic bougie. I can't emphasize it enough. I think that's the highest yield airway adjunct of everything I've talked about. You have all your equipment set up and ready to go. Make sure that you are ready to place some sort of rescue airway. I'm not saying you have to open the rescue airway every single time, but at least have it out of the bag and maybe on the patient's anterior chest wall or on the action wall next to your stretcher or somewhere that you can easily get to, right? Because if you don't take out the rescue airway, you'll find yourself scrambling for it in a difficult situation. All right, so lots more to airway management, just getting the tube in. It's part of the resuscitation. It's the goal of the airway management is to really have a well resuscitated, well ventilated, airway protected patient at the end of the day. And you got to make sure you do this difficult airway assessment so that you're prepared for an airway that might be difficult. which will help you kind of see a couple steps ahead in terms of your decision. So that being said, I apologize for going over my time. Any questions? Happy to look at the chat or my email address. You can feel free to email me. My info is up here on the screen.
And the key point, Alvin, is spending that 30 seconds knowing it's a difficult airway, preparing for that difficult airway can save you 5 to 10 minutes of an oxygenated patient with multiple attempts.
Yep, totally right. That airway assessment is the key to it, and I know everyone's heard about it. We sometimes only median do it, but really, I challenge you to do a good job with that airway assessment the next time you do any kind of, or before you do any kind of intubation in the future. All right. Out of respect for everyone's time, I don't want to keep going on, but thanks again for having me out tonight. I hope this was a useful presentation for you.
Thanks, Alvin. That was awesome.